I'm opening the meeting. I'm chair of the Royal Statistical Society's official statistics section, which is holding this meeting jointly with the Health Statistics User Group. And I'd like to welcome you virtually to the Royal Statistical Society. I particularly thank Luz Martinez from the RSS, who is facilitating the meeting. We think it's very important. The focus of this meeting is on methods, but it will include some very up-to-date data about vaccinations and also a signpost to data we can't include as they're not yet published, but will be coming out soon. I'm now going to hand over to Dina Ledbetter, Chair of the Health Statistics User Group, who's going to chair the meeting.
Thanks, Alison. So welcome from me as well. So can we move to the housekeeping? Yes, so there's always that little bit of housekeeping. So welcome to everybody, and also, thanks in advance to all the speakers. Reminding them of the usual things, if you could keep yourselves muted throughout, and then please submit your questions through the chat, and we will endeavour to answer them in the Q&A at the end, and also we give speakers an opportunity to answer more fully afterwards. So please, contribute in that way. And this is being recorded, and we make that available for a few weeks afterwards, maybe a little bit longer than 2, but that's just because things change so fast, so we don't keep it up for that long. But the presentations are all available immediately afterwards. There's a lot of material in the presentations, so don't expect to be able to read them and digest them as the speakers are running through. They're really just introducing the topics, and hopefully you'll be able to go afterwards and look at them in more detail. I mean, every one of those, some of those slides you might want to take several minutes over, so don't worry if it's running through quite quickly. All the slides will be available afterwards. Okay, the next slide, please, Luz. Which is yes. So just to introduce the idea, and these webinars are intended to be collaborative exchange of ideas, and so therefore we do welcome comments in the discussion, but this is around sharing, and hopefully by sharing improving. So that's the kind of ethos of this webinar, and we continue to take comments afterwards, so feel free to continue to join in the debate. And as Alison said, there are some things that are just coming out now. Anything that comes out later, we will also be posting that. So let's then move on briefly to the speakers. Oops, is that? Yeah, okay. So thank you very much. So we have speakers from Scotland, from England, and from Wales, which very pleased. We didn't actually have Wales on the previous one. Diane and Chris, people who attended the last webinar will remember from the last webinar, and they're giving us an update on the vaccination statistics in Scotland. As far as Public Health England is concerned, Colin isn't able to attend the actual webinar itself, but Camille Tang is actually sort of stepping in to present the slides. So thanks to Camille for that. And then Ted Darby will be talking about some of the work that ONS is doing on vaccination rates. We did mention around the work on infections and mortality in some of the earlier publicity. That's not ready yet, but when it is, we will be posting information about that on the website. So look out for that afterwards. It won't be covered in this presentation. And then the final speaker is Simon from Wales. As with previous webinars, we will run through all the speakers one after another without very much further introduction between them. And then at the end, we'll do the Q&A with questions to all the speakers and giving them an opportunity to respond to the one specifically aimed at them. So that really is the housekeeping bit. And so without much more detail, I'd like to hand over to our first speaker, who is Diane Stockton from Public Health Scotland.
Thank you. Thanks. Next slide, please. Thank you. So I'm just going to talk a little bit about the surveillance programme in Scotland, but focusing on the uptake data. And Chris Robertson will talk about the vaccine effectiveness results from Scotland in a minute. But just to also mention that we do publish quite a lot of other information as well. So recently we did a report on did not attends. We publish information on individuals diagnosed, hospitalised and dying from COVID around vaccination status. And we also do quite a lot of internal work on vaccine failures and safety as well. So and some of that gets published within Chris's work. Next slide, please. So just focusing on what we're seeing at the moment in Scotland around vaccine uptake. We have a dashboard which is updated daily. Also, you can also access the underlying data from the dashboard as well if you're interested in the open data. And at the moment, what we're seeing is extremely high uptake across the from 55-year-olds upwards in Scotland. This is based on the National Records for Scotland population estimates, which are like equivalent to the ONS ones for England. So not based on GP registrations, which some uptake figures that you see are based on. So this is based on the NRS population estimates. And you can see the dark blue is the first dose and the lighter blue is the second dose. For 50 to 54-year-olds, the uptake is also looking very high. We think we're probably around beginning to plateau now in terms of first doses for that age group. And most second doses have been received. And for the 40 to 49s, we're still seeing a slight increase day on day on the number of people coming through in that age group, but we have reached, I think we will not be long now before we reach plateau in that age group. We are seeing a little bit of vaccine hesitancy around AstraZeneca for second doses, so keen to promote the safety of the second doses in those age groups. But the second dose figures for the 40 to 49 are just because the 8-week window mainly because the 8-week window hasn't been reached yet for them. And you can also see the uptake rates in the younger age groups as well in that graph. Next slide, please. This, not to go into too much detail, but this shows the variation between our local authorities. This is for all 18 plus. And you can see there's a bit of variation, but generally, fairly similar levels of uptake across the local authorities in terms of dose 1 and dose 2. Next slide, please. And the dashboard also looks at uptake by some of the JCVI categories, and you can see that this is the latest on the kind of second dose coverage for those specific categories that are not age related, some of which we haven't got denominators for, so we can't do an uptake rate, for example, carers, but some we've had a go at doing an uptake rate for. Next slide, please. The other thing that we publish monthly is information on uptake by ethnic group, and these are the high-level groupings, and we also publish on the website the more detailed census-based ethnic groupings. The main take-homes from the work is that African groups and Polish groups, which you can't see on here, but you can see on the more detailed data, have lower uptake, and there's a lot of work going on in Scotland around trying to boost vaccine confidence particularly among these groups, but also among other groups where the uptake has been lower. We consistently see the highest uptake in the white groups, and also high uptake generally in Asian groups. Next slide, please. And we also look by deprivation, and this is showing the black lines are the most deprived people living in most deprived areas in Scotland, and the green are the least deprived areas. And you can see that as we move down the age groups, we're finding a bigger variation between the two. So overall, for all 40 plus, we've got a difference of 7% vaccination uptake, although it's worth noting that compared to other Other things we look at around health, the gradient between most and least deprived is less than we often see in other areas, but there's still opportunities, I think, to try and boost uptake in more deprived areas, and work is ongoing to try and do that. Next slide, please. And then just also to note that we do also look at some specific groups where we can. So recently we looked at uptake among registered school teachers, and this is out of date now. But we looked at we were looking at specifically what proportion of teachers would have had 2 doses by the time the schools return in Scotland, which is in mid-August. So that was used for that purpose. We're also currently looking at uptake in prisoners, and we've looked at uptake in other specific groups where we can use linkage to identify cohorts of particular interest. So thank you. That's all from me. Thank you.
So if we hand over straight to Chris.
Okay, so I'm going to report on work that an academic collaboration between Public Health Scotland and the universities down there. All of the data in this slides have been published in a Lancet letter a couple of weeks ago. Next slide, please. So this is one of the first of the detailed slides about the methodology. The aim of this investigation was actually to look at the Delta variant, or whether or not the S gene was positive. And we can only do that from the community testing laboratory in Scotland, which is known as the Lighthouse Lab. And in Scotland, there's only one Lighthouse Lab for the whole country, and that gives us information on the Alpha variant, or the Kent variant, which was S negative, and the Delta variant, the one from India, which was S positive. And the data are a linkage of GP data for our clinical characteristics and the denominator, then linking into the testing data set and linking into the rapid hospital admission data set, and also deaths data, but there have been very few of these so far. So the next slide, please. This just gives the definition of hospital admission, which was admitted with a positive test within 14 days of the test, or if you were tested positive in the first 2 days of hospital admission. And the vaccination groups we looked at were 1 dose of the vaccination up to 28 days, then 28 days or more, then 2 doses, and the split was at 14 days there. The next slide, please. So it's always easier when you start talking about data, and this gives information from the surveillance in the community tested data only. And what this sees, the S positives are the red line. And what you see that when the lockdown started in January, the S positive cases shot down dramatically until March, April time, when they were getting on for a handful of S positive cases in Scotland every day. So that version had pretty well been eliminated. But when the Delta variant came along at the end of April and lockdown was also eased, then the Delta variant, the S positives, increased phenomenally, and now they've overtaken the S negatives, which are the Alpha variant, in the later time series. Okay, next slide, please. This is looking at the data that's available to us, and what we've got at this time, there were about 20,000 cases in Scotland up to the 6th of June, and 19,500 of them linked into the EVE cohort. For the clinical risk group information, the table on the left gives the gender split, and you can see it's pretty well equally balanced at this stage. That position's actually changed in the last week. And the sequencing data from which you actually know whether or not it's an Alpha or Delta variant, that's done on about 70% of the Scottish positive samples there. And the table on the right, at the bottom right, shows you the high degree of correspondence between S positivity and the Delta variant, and S negativity and the Alpha variant. So all of the analysis is going to be carried out on whether the S gene is positive or negative. but it's pretty well equivalent to whether you've got the alpha variant or the delta variant. The reason we're using S positivity is that gives us much more up-to-date data, to the previous day, whereas for sequencing, we have to wait a couple of weeks to do the analysis. So next slide, please. This shows the age distribution of the cases since April to the first week in June. And what you can see on the bar charts is that the weak positives, which are the blue line, are largely concentrated amongst children, or there's a greater proportion of weak positives in children there. For the positive S gene and the negative S gene, the green and the orange bars, they're pretty well the same, but a slight excess of S positives amongst primary school children 5 to 9 and also in 20 to 24s. There's not really very much difference there. Okay, next slide, please. This one shows hospital admissions. The graph on the left is the daily admissions to hospital with a positive test. That's using all tests in Scotland, so it includes the NHS laboratories for which we don't have S gene status. But what you can see there is that hospital admissions were going down very, very linearly almost till a peak or a nadir at the beginning of May. And with the upturn in cases at the end of April, then hospital admissions started increasing towards the end of May, beginning of June. And the histograms on the right show that in the later period, pretty well all of the hospital admissions were associated with the Delta variant or the S gene positive there. So what we're seeing is that this uptick in hospital admissions is largely driven by the Delta variant, and the aim of our analysis was to see whether or not the Delta variant was more associated with hospital admissions and whether or not the vaccination worked equally well in the Delta variant or the Alpha variant. So the next slide, please. So here we've got the results for every individual who tested positive in Scotland from April to the 6th of June. That's the denominators, the N in that table. The number of admitted shows you the admissions to hospital, and it's split by whether or not you're S positive, which is the second row, or S negative, which is the dropout row. And what you can see on the last column is that the rate of admission is greater if you were S positive compared to S negative. Now that's a crude figure, and it's not adjusted for the case mix, the age of the patients and their comorbidities. So the next slide, please. So what we're doing in this one is using a Cox regression model for the time from testing positive to admission to hospital. These are all community tested individuals, so they're admitted because they've got symptoms associated with coronavirus. So it's an admission for coronavirus. And in the hazard ratios at the top, you see the hazard ratios associated with S gene status. And so adjusting for clinical risk groups, vaccination, deprivation, gender and trend over time. If you're S positive, so the Delta variant, then you've got an 85% increased risk of hospital admission compared to the S negative. So this is one of the first demonstrations that the Delta variant was associated with more severe outcomes there. Down at the bottom of the table, we've got the vaccine effect at, even although you're technically some type of vaccine failure in that you've got a positive coronavirus test result after vaccination, the hazard ratios among the vaccinated are all below 1. And that suggests that even if you're vaccinated and you're tested positive, your odds, your hazard of going into hospital is actually less than if you're unvaccinated. So it's about a 70% reduction in the hazard of going into hospital. So the next slide, please. So in this case slide here, what I've fitted are interaction models. And in order to do that, I have combined some vaccination groups. So dose 1, 28 days, or any value of dose 2, they're combined together. And unvaccinated and dose 1 up to 27 days are separated. That's a typo there where it says they're combined. So within this table here, the first 3 rows correspond to the people who are unvaccinated. So unvaccinated S positives have got a 70% increased risk of hospitalisation. The next 3 rows are the effects of vaccination if you're in one of these dose groups, so 1 dose, 28 days, or 2 dose. And what you can see is that they are all hazard ratios of about 0.3 for the S negatives and 0.46 for the S positives. So what that means is, given you've tested positive, the vaccine effect for the alpha variant is about 70%. And if you test positive, but you've got the delta variant, the vaccine effect's about 54% there. Both of these indicate protective effects of vaccination on admission to hospital, even if you actually test positive for coronavirus. So the next slide, please. That just gives the conclusions from this work, which are in the letter to the Lancet. So there were slight demographic differences between S genes, positive and negative, but not startling differences. There are actually few hospital admissions, but there's an increasing risk of hospitalisation with the Delta variant S positive, and vaccination, particularly if you've had 1 dose for 28 days or 2 doses, you've got a reduced risk of hospitalisation. At the minute, these differences aren't statistically significant, but in terms of vaccine effect, it's possibly slightly lower with the positive gene. And that's all I need to say. So thanks very much.
Thanks very much, Chris and Diane, for that overview for Scotland. And now we're going to move on to England. And the first speaker is looking at work from Public Health England. So this is now Camille, who's obviously stepped in for Colin. Camille, over to you.
Hi, thanks. First slide, please. So just a little bit about the data. In the last session, we did a little bit more about how we calculated vaccine uptake. So this time around, we'll be showing some of the data. So just a reminder that the data presented here is from the point of care apps that are extracted from the National Immunisation Management Service, which is essentially a national vaccine register. So all the data that we are presenting here is for last week's data that are being published today. The denominators are from the same source, so numerator denominator from the same source, and also that the data is only presented for the living resident population. So all deaths are removed. Next slide, please. So this is the national data table by age. You can see very much that in the 60 plus, we've got over 90% uptake in the over 60s, and very similar rising uptake in the dose 2s as well. These are starting to plateau, so you'll see that on the next slide. And this includes everybody in the population, so it's not capped at the 18 plus, like some data is on the UK COVID dashboard, which we'll have a look at later. Next slide, please. So this is over the same data, but by week. So you can see how a lot of the data in the older age groups is starting to plateau. And we're getting this nice rise in the 40s. We're hoping to break that down further, probably in the next couple of weeks. So if you go to the next slide, you'll see the same graph for dose 2. Next slide, please. Yep, that's still dose 1, I think. So we might have, there we go, dose 2. Great. So again, there's what's really interesting about this graph, it shows quite nicely the sort of policy change in week 1, where we were told to sort of stand down the dose 2s for a period of time. And that's what's happening in the over 80s, that sort of plateau at the start from week 1 to week 9. And then as the different cohorts came online, you have this really nice staggered effect. Next slide, please. So as you can see, we do have data for the lower age bands. So this is the age sex pyramid going down to 18 to 24s. So the candy bar canes at the bottom is the change from the previous week. So you can see that the vast majority of the dose 1 is being delivered in the younger age cohorts that have now become eligible in England. And for dose 2, if you for the next slide, please. You can see that the dose 2s are coming up mainly in the sort of 40 plus year olds, which are coming up to the sort of 8 to 12 weeks since they became eligible in early, I think it was early April. Yeah. Next slide, please. There are some slides there'll be some additional data that'll come in the slides after the publication. So vaccine uptake varies quite a lot by ethnicity. We do publish some broad ethnic groups in the weekly flu COVID surveillance report, and also by region in the backing tables. So there'll be some data for that too. One of the things to highlight about ethnicity is that when you look at percentage uptake, it can skew the data in the sense that it varies quite a lot by geography as well. So when we're looking at ethnicity, we try to also have the actual numbers. So you're looking for the highest numbers of unvaccinated individuals, which will differ for different regions. Next slide, please. So now we'll introduce some of the UK COVID dashboard data. Most of this is going to be visuals that are available for the England data. Slow progress is being made to try and get the same data from the other devolved administrations. So it's just a snippet of what's to come for the whole of the UK data. So the difference between the UK COVID dashboard data at the UK level is that the denominator that is used to produce the vaccine uptake is using ONS mid-year estimates for 2019. There are discussions underway to shift that to the 2020 mid-year estimates, but we've not quite settled on date yet for that. So this is just for the UK, it's using ONS denominators, but anything further in England is using NIMS denominators, which is now presenting down to MSOA level. Next slide, please. So we have a graph for vaccinations by day. So it's very, this is the non-cumulative vaccinations given by day. There is a little tab for cumulative data, and there's lots of caveats that you can read about the data if you do go on the website to look for these visuals. Next slide, please. Yep, so there's this heat map as well that goes down by age. So the darker purple is where you have the highest uptake, and the lighter purple is when you have the lowest uptake. So this is over time, so we would hope that it becomes darker purple as time goes on. Next slide, please. That's the same one. Click again. And if you click again. Right, so the top heat map is the daily case rates. So the darker purple is when you have the higher case rates, and the greens and yellows where you have the lower case rates. And then using the same heat map from before of vaccination rates, this is kind of trying to put show a sort of visual of how vaccination is changing the dynamics of the pandemic. It's not indicating sort of vaccine effectiveness. It's not the proper way to do it, but it's just a very nice visual to show the changing dynamics of the pandemic due to vaccination. If you could click, so you can see that with the dark purple at the bottom, you've now got the sort of light yellow and green at the top, whereas before you had the higher case rates across the board and in the elder population earlier on in the pandemic when we didn't have vaccination. Next slide, please. Yep, so case rates now low in older ages, and again, and those who have high dose 2 uptake. Great. So a new functionality that's been introduced, I think, published yesterday or today on the UK dashboard is a lovely map showing coverage of first and second dose. You have this little slider. So the darker green is you slide it to the left, you get the second dose, slide to the right, you get the first dose. So you can zoom all the way down to MSOA level, which is quite nice. Next slide, please. Here's the uptake in the Northwest, which is of particular interest around variants. So what's very interesting at the moment is we're seeing quite low uptake in the centre of the city, but it's not necessarily related to deprivation, and actually is around the student areas. So it'd be really interesting come September when the new academic year starts, how that might change and how that might change over the next few weeks now that a lot of this, a lot of the younger age groups are now eligible to be vaccinated. So hopefully we'll see more of that turning dark green, but it does give you that nice geographical granularity for local public health interventions. Next slide, please. And likewise for dose 2, similar patterns. Next slide, please. And here are some useful links for where all the data is in the public domain. And I think we've got one less slide, and that's it from us. Thank you.
Thank you very much, Camille. So now we move on, still staying in England, but move on to work by ONS. So Ted Dolby from ONS will talk about this.
Hello, hi, I'm Ted Dolby from the Office of National Statistics, and I'll be talking through some of our work analysing COVID-19 vaccination rates by various socio-demographic characteristics, mainly sourced from the 2011 census. Next slide, please. So I will first just talk through the data set that we're using here. So we're taking information from the 2011 census, predominantly date of birth, sex, and other socio-demographic characteristics. We're linking on the GP extraction service data from November 2019 to give information on underlying health conditions and to give us a more up-to-date area of residence. And then finally, we're linking on the death registration so that we can remove those that have died since the 2011 census and also those that have died during the period of study. This is what forms what we've called the ONS Public Health Data Asset. And for this work, we have linked on the administrative vaccination data from the National Immunisation Management Service dataset, which Camille had just talked about. Next slide, please. And what this gives us is a study population, which is as follows. We have people aged 40 years and over who were alive on the 15th of May 2021 for this publication. Those who were resident in England, registered with a GP in 2019, and were enumerated at the 2011 census, It's worth pointing out the age restriction of 40 years of over is just due to the timing of this publication. At the 15th of May, producing estimates below that age group wasn't quite feasible yet. What this does give us is a study population that is a subset of the population, predominantly imposed by that the fact that everyone needed to be enumerated at the 2011 census. This means that those that didn't respond to the 2011 census or those that have immigrated into England since 2011 won't be included in the dataset. Similarly, those that weren't registered with a GP in 2019 won't be included either. What this results in is that of people aged 40 years and over who received a first dose COVID-19 vaccination, according to the NIMS dataset, we were able to link 84.6% onto the ONS public health data asset. Next slide, please. And so we can talk through some of the findings that we found in this analysis. Next slide, please. So we can first look at ethnic group as a socio-demographic factor. With the left-hand chart showing the crude COVID-19 vaccination rates, that is the proportion of people vaccinated. And we can see the highest rates in the white British group, over 90%, and those in the Pakistani, Black African and Black Caribbean groups seeing the lowest COVID-19 vaccination rates. This is for first dose only and will be for the rest of these findings. On the right-hand side, what we can do with our data set is we can run a logistic regression model to estimate the odds ratios of not having received the first dose of a COVID-19 vaccination. In this case, we're using the white British group as our reference group. So the dark blue bars here, those labelled as unadjusted, these represent kind of the raw differences that we can see between the white British group and all other ethnic groups on the left-hand bar chart. What we can then do is add controls to our model, so we can adjust for age and sex in the age and sex profiles of the ethnic groups, which give us the lighter blue middle bars. And finally, we can impose a fully adjusted model where we adjust for the age and sex profiles of an ethnic group, as well as socio-demographic factors, the geographic factors and underlying health conditions within each of the ethnic groups, which produce the teal bars, the third bars. What we can see here is that despite controlling for all of these factors, we have odds ratios that are more than 1 for all of the ethnic groups when using the white British group as a reference group, which means that we see that all ethnic groups were less likely to have been vaccinated when compared with the white British group. Next slide, please. And then we can repeat this exercise for other socio-demographic factors. So this is using the fully adjusted model, and we're now looking at the religious affiliation as recorded on the 2011 census. Here we're using the Christian group as our reference group, and we can see that those identifying as Hindu, Jewish or Sikh actually had an odds ratio of less than 1, suggesting that they were more likely to be vaccinated than those in the Christian group. Meanwhile, those identifying as Buddhist, Muslim or other religion were much less likely to have received a first dose vaccination when compared with the Christian group. Next slide, please. We can also look at English language proficiency as recorded on the 2011 census, although this does come with some caveats, as it's possible that people's English language proficiency will have changed since this was recorded in 2011, though we do see some interesting findings. When using the English being a person's main language as the reference group, we see that all other groups have an odds ratio of more than 1, suggesting that they were less likely to have received a first dose vaccination. And we also see a trend as English language proficiency diminishes down to those that don't speak English, the reported not speaking English at all. We see that these people were much less likely to have received a vaccine. Next slide, please. We can also look at kind of socioeconomic indicators. In this case, we look at the area deprivation of where an individual is living as measured by the index of multiple deprivation. Here we're looking at the quintiles. Our reference group is the quintile 5, which is those that are living in the least deprived areas. We see that those all of the quintiles have an odds ratio of more than 1, suggesting that more deprived areas will those living in more deprived areas were less likely to have received a vaccine. And we see again a trend as we move towards the most deprived areas, we see an increasing likelihood of not receiving a vaccine. Next slide, please. So with our data set, with it being linked to the census, we can look at individual level socioeconomic indicators. Here we're looking at the National Statistics Socioeconomic Classification, or NSSEC, which is linked to a person's occupation. The reference group here is the higher managerial, administrative and professional occupations, which are seen as the most socially advantaged group. And again, we see that all other groups were less likely to have been vaccinated than this most socially advantaged group. Particularly, we see those in the never worked and long-term unemployed group, who are the least socially advantaged classification, having the highest odds ratios, suggesting that these are the people least likely to have received a first dose vaccination. Next slide, please. Finally, we can look at disability status, again recorded at the time of the 2011 census, with our reference group being those that were not disabled, reporting not being limited in day-to-day activities. And we again see that those that reported being limited a little and limited a lot in day-to-day activities, having odds ratios of higher than 1, and therefore being less likely to have been vaccinated than those that were not disabled. Next slide, please. So we've also done some work on vaccine attrition. This is looking at those among those that have received a first dose vaccination, what proportion and what rates had progressed on to receiving a second dose. At the time of this publication, we'd only looked at those that were 70 years and older. So this was the only feasible age groups. Next slide, please. So again, this is the study population, again, slightly different, with only looking at those 70 years and over, and obviously different deadlines on the study period. Here we're looking at the 9th of May. The main thing to note is that we're only looking at those who had received a first dose vaccination by the 15th of March. This was to allow sufficient time by the 9th of May for them to have received a second dose. And next slide, please. I won't go through all of the socio-demographic factors, as I'll explain now. Looking at the ethnic group, we can see very much similar pattern, with the white British group having the highest second dose vaccination rates among those that received a first dose, and those in Pakistani, Black African and Black Caribbean groups having the lowest rates. We do also note that the Bangladeshi group has lower second dose uptake when looking among those that received a first dose. I've included slides for the other socio-demographic factors, but won't present them here, as we see roughly the same patterns across first dose vaccination rates and second dose vaccination rates. Although, as seen here, we do see a slight diminished difference between the groups, which is to be expected when we're looking among those that had already received a first dose. So I'll leave it there for now, but please feel free to look at the slide pack to see the other socio-demographic factors.
That's great. Thanks very much, Ted. Yeah, and so obviously there's more in the slide pack now, and then also when further work is carried out, we'll be posting that as well. So keep an eye on the website. So now we move on to the situation in Wales, and pleased that Simon Cottrell is going to be able to present that for us. So over to you, Simon, vaccine coverage in Wales.
Thank you. Next slide, please. Okay, so thanks for inviting participation for Wales to this meeting. I don't think we're at the last meeting. So to start with, just to explain the approach and the aims of this in Wales. We approached it very much from a surveillance point of view. We've got surveillance programmes that operate for all vaccination programmes in Wales. And the key aspect of that is that we need to provide timely and systematic feedback to the providers of vaccinations to guide their actions. And coverage is just one of a number of measures of success in vaccination programmes. When we talk about percentage coverage, it's actually the percentage of people who haven't been vaccinated that's the most important thing. And to make that operationally useful, we need to know a bit about those people who haven't been vaccinated. So what characteristics do they share? Where are they located? To do this in Wales, we routinely provide surveillance reports back to the health service at a variety of levels, so by geography down to MSOA level as routine. We look at aspects of risk, so age group, clinical risk, level of deprivation and ethnic group. And we also produce provider level statistics from organisation down to GP level. And those go back to the people at the coalface delivering the vaccines to help them. We also provide public facing reports and operational reports to government. So we've got a daily SITREP that goes to the Welsh Government and onwards to the UK Government. We decided fairly early on that to give us the flexibility to do all of this, we really needed a vaccine registry approach in Wales. So all of the data that I'm going to show you is based from our vaccine register. The added benefit of that as well is that it allows us to do some of the enhanced surveillance work around vaccine equality, vaccine effectiveness, adverse events and safety monitoring by linking to other data sets. Next slide, please. So the vaccine registry in Wales is called the Welsh Immunisation System, WIS. It's been built and it's managed by our colleagues in Digital Healthcare Wales. We were very lucky that we were able to provide input right from the outset, so that the system was able to provide us with the surveillance data that we need, as were a number of other organisations in Wales. It's based on Welsh demographics data, which originates in general practices, but it's been enhanced with other data sets. So clinical risk data, priority group data, occupational data, lots of demographic data, and of course the vaccination data also feeds in. The main purpose of the system really is to invite people and arrange their appointments, and it also enables follow-up and recall for people who've missed their appointments. And that universal appointment and universal offer is one of the most effective ways of eliminating inequalities in vaccination coverage, and there's a lot of evidence that's been published around that. The system allows for point-to-vaccination data entry at the vaccination sessions, but it's got a paper backup in case there's any hardware failures. And it provides us with all of the surveillance data that we use or that we link to other data sets. And as Camille highlighted earlier, vaccine registries allow you to be sure that your numerator data and your denominator data are well matched. There are a couple of downsides to vaccine registries. So it relies on people with NHS registrations, so it's potentially lacking on some underserved groups. With WIS, there is the option to add people on even if they don't have an NHS number in a temporary capacity, and then they get deduplicated when their NHS number comes through. But even with that, it's going to lack some information. And some vaccine registries can lead to denominator inflation, where people may have moved away from the area, but they don't let the healthcare provider know. One of the ways that you can combat that is to provide routine feedback and surveillance reports back to the vaccination providers, because they know who's on their lists, and that really helps with the data quality assurance. Next slide, please. And this is where we are with the vaccine programme in Wales. So we're rapidly approaching the stage where we've got 90% coverage of the first dose for all adults in Wales, and approaching 50% for the second dose. You can see the green bars are completed courses, and the blue bars show you the people who've had one dose and are awaiting their second dose. And the rate of uptake in the youngest age groups is progressing fairly rapidly. Next slide, please. So I'm going to spend the rest of the slides talking about our surveillance for equality of coverage. And for this, we use WIS as our data source, but we link it to a number of other data sets, either through the SAIL data bank or through our own methods. We look at equality of coverage on a monthly basis by sex, and that's using sex as recorded in WIS, by socioeconomic deprivation, where we link to the Welsh Index of Multiple Deprivation at LSOA level, and by ethnic group. And we use a method that's been developed in SAIL for that, where we link to the census data, and then the data sets topped up with around 30 other different health data sets in Wales to improve the completeness of recording. All of our data gets published in a monthly report, and the most recent one was published on the 18th with data as at the 6th of June. Next slide, please. I won't spend too much time on this slide, but it shows you that there are small but significant differences in coverage by sex. But as you go down the age groups, the differences get larger. We think one of the reasons for this may be that there's a higher proportion of females who work in health and social care in Wales, and they've been eligible for the vaccination for longer. So we may be looking at inequalities in timeliness of vaccination here rather than inequalities in vaccination per se. And you can see that the second dose differences are a little bit larger than the first dose differences. Next slide, please. The biggest inequality that we see is in coverage between the ethnic groups. And then the slide on the left-hand side here, we've got coverage for the combined Black, Asian, mixed and other ethnic groups compared to the combined white ethnic groups. And you can see for all of the age group, there's a significant inequality gap. In the data on the right-hand side, in the light blue, we've got the most recent figures, and then alongside that, in either green or red, we've got the previous inequality gap for the last month. You can see for the older adults, the gap's narrowing, which is good, but for the younger adults, the gap's widening. And this again may be to do with differences in the proportion of health and social care workers or the proportion of people with clinical risks who have been eligible for vaccination for longer. I think based on what we've seen so far, we'd expect those inequality gaps in the younger adults to narrow as time goes on, but it's something that we need to be vigilant for. The take-home message about the narrowing of the inequality gaps is again that we're not potentially looking at inequalities in vaccination coverage or uptake, but perhaps inequalities in timeliness of vaccination and the approaches that some people may have to wait and see and not want to be the first to be vaccinated in their social group. Next slide, please. And this shows you the narrowing of the inequality gap over time. So it's by age group, and the people aged 80 years and older have been eligible for the longest. And you can see that the gap continues to narrow there, although it is still significantly different between the combined groups. And next slide, please. When we look at differences by socioeconomic deprivation, there's a smaller inequality gap, but it's still statistically significant. And the data is presented in the same way here. So the numbers in light blue in the text on the left-hand side of the current gap, and we've compared it to what it was for the previous month. And again, you can see for the older adults, it's narrowing, but for the younger adults, there's a slight widening. And again, this may be related to higher prevalence of clinical risks that would have made people eligible for vaccination for longer in the younger risk groups, but it's something to be vigilant of going forwards. And again, we're seeing that pattern where it's timeliness in some cases rather than opting out. And it really reinforces that it's important to repeatedly offer vaccinations and to reoffer appointments that may have been missed. Next slide, please. And this shows you the narrowing in the inequality gaps between the most and the least deprived quintile of lower super output areas in Wales. And you can see that as time goes on, coverage increases across all of the groups, and the gap is showing some signs of narrowing. Next slide, please. As with the other vaccine programs that we carry out this surveillance for, inequalities in the second dose usually higher than inequalities in the first dose, which is not surprising, as we're looking at a combined effect of the timeliness and the uptake in both doses. And that's something that we're seeing in the COVID vaccination program as well. Next slide, please. And this last one slide just summarises where we are so far. So the vaccine registry approach really allows us to be flexible in our analysis and to provide operationally useful data in more or less real time back to the coalface. We've seen that there are important inequalities in coverage between ethnic groups, socioeconomic deprivation and also sexes. But as time goes on, coverage is increasing in all of the groups, and the gaps are more or less narrowing in all of the groups to a greater or lesser extent. Surveillance of vaccination equality is really very important in understanding how your unvaccinated population may be clustered. And it's key really to guiding some of the public health interventions to improve uptake. And this data gets fed back to various groups looking at different aspects of equality and underserved populations. And for COVID, it's especially important because a lot of the groups that we're talking about having lower uptake are the groups that we know are at more risk of severe outcomes from COVID. We've got a fairly good level of surveillance in Wales on this, but acknowledging that there are limitations. especially around some of the more invisible, underserved groups to the system. So we're looking at developing methods to estimate coverage in people who may be at higher risk of homelessness or have recently moved to Wales and maybe not registered in the system yet. And that's in collaboration with the Welsh Government Vaccine Equity Committee. And I think it's the last slide next, which is to thank a number of people. Well, I won't go one by one, but it's a team effort in Wales. Thank you.
Thanks very much, Simon. That was fascinating. It was really interesting, the slightly different approach of how it's being tackled in Wales, which obviously is got some great advantages, although you highlighted obviously some of the problems as well. So this now reaches the end of the presentations, and we move on to the Q&A session. We've got, normally in these webinars, Manira is the person who does this, but actually she's not able to attend today. So Alison hopefully has been looking at some of the questions. I've been looking at them on the side. There's some general ones, but obviously some specific ones. And I know not everyone can actually see the chat because they are, if you actually log on from your phone or something, you can't actually see all the chat. So we'll try and pull out some of those questions, and then if the speakers could kind of unmute themselves, and so we can actually see them, and then we can pick up with them some of those questions. I know some of the speakers have been responding within the chat, so we will be capturing all of that and including it in the report. But since not everyone's seen that, it would be good to have some summaries from the speakers on some of the thoughts in the chat. So Alison, are you able to pick up on the questions?
I've been taking a note, and also now going back to the specific questions and replies. And of course, there's a lot on what denominators people were using, and also what linkages and what systems, and what quite a feature is that the diversity of approaches, which all have positives and negatives. It's not difficult to see why it's difficult to produce UK figures. So I've been taking a note as I went along, but I'm just going to go through as we go. The first question to Diane Stockton was whether there are any statistics on people who had COVID, and her original reply was that they hadn't looked at this specifically. Obviously, some of this links to the Strathclyde presentation. Would either of you want to say any more about that?
Hi, yeah, I'd taken that question as being about uptake rates. So we haven't specifically looked at uptake rates in people that are on our system as having had COVID. It's something that we could do, but we haven't done that at the moment. But if that wasn't the question, then I don't know if, Chris, you've looked at that as part of your work, but.
Yeah, we had an analysis of first dose failures, so hospitalisation or death 14 days or more after your first dose amongst all people who had a first dose vaccination. And it's under review, the paper, but the basic results are that these failures are in elderly. They're more common if you've got multiple comorbidities, if you're a smoker, high blood pressure, things like that. But one of the other interesting things was that for individuals who had previously tested positive for coronavirus, they had a reduction in the risk of a first dose failure of about 70%. So effectively their first dose is like a second dose because they've already had coronavirus beforehand. But we haven't really looked at uptake amongst people who have been previously positive to see whether they took their vaccination with greater alacrity or less than people who hadn't had tested positive.
And the next question, again, for Scotland, and Colin's already touched on that. Is the Scottish data available on age and underlying conditions, stroke frailty for Delta hospitalisation cases after 2 vaccine doses? It's obviously only indicative in the small sample. And Right. I think you'd answered some of that, but equally the numbers are quite small. So it's
Colin wants to come in there, I think. Colin.
Yeah, I can't see that particular question, but I mean, there's obviously quite a lot of interest in and a lot of questions that are occurring about sort of vaccination status in people who've hospitalized and died in general and who've had new variants, etc. Now, it's quite difficult to interpret that data, and we have to be very careful. So I apologize, I've missed the first half of the presentation, but we were due to have a presentation of vaccine effectiveness from Jamie, and the way to answer these questions formally is through a proper vaccine effectiveness analysis. And it's important to point out that in the context of very high vaccine coverage, even with a highly effective vaccine, we expect that a large proportion of cases will occur in vaccinated people. That's simply because we have a large proportion of the population is vaccinated. Yeah, so it's difficult to interpret simple data on proportions who are hospitalized and died and who have been vaccinated. That's a caveat I would like to add there.
thanks.
I saw that was on the fact check. I think it was on the BBC website where someone had actually been saying around this fact that there was all these people who've been vaccinated and hospitalised, and actually trying to explain exactly what you have explained, which is it's a very complex thing to interpret once we get a high level of vaccinations. Is that Chris with your hand up?
Yeah, it was just when I responded to the question, the other thing I pointed out is that a lot of the definitions of being in hospital with coronavirus are looking at whether you tested positive and admitted to hospital. It's not necessary that you were admitted because of the coronavirus. It may be an incidental finding because there's a lot of asymptomatic testing of patients either on admission to hospital or while they're in hospital. So a lot are picked up that way. The analyses, as Colin mentioned, are really quite complex to try and work out any associations there. And the other thing is, at the minute, the people who were vaccinated first were precisely the elderly and the ones who were in multiple risk groups. So they're the ones who are most likely to have the second dose for a long time. So you won't find many 20-year-olds with a second dose failures because there are very few 20 to 25-year-olds vaccinated with 2 doses.
Thanks. The next, right, and this is, are there comparative studies to explain why England's uptake rates are lower than Scotland? And again, I think, Chris, whether it's you or Diane, excuse me, whether it's you, Diane are going to answer this, or both of you have something to say. You mentioned the analysis you've been doing within the EVE study. Would you like to? Right, you've already said this. So these the 2-dose hospitalisations are picked up when testing in hospital of asymptomatic people, and that the most of the hospital with 2 doses are people with, that's what you just said, with elderly and with disabilities. I think
so Diane, you've got your hand up. So do you want, Diane, do you want to chip in here?
About the
yeah, well, just on that specific question about uptake, so we do have so the data that's been presented today is not using the same denominators, whereas we do, there is national data published with the same denominators. So it was just to make that point that, we're looking at, in this particular work that we're presenting today, the English data was using the NIMS denominator and the Scottish data was using published population estimates, and the uptake does, is different depending on those two. So in Scotland we don't have NIMS, but we have we have obviously GP registrations, and there's a lot of work going on trying to look at how we make sure they're as accurate as possible to remove individuals that have left the country or etc. from that to get accurate denominators.
And Camille, you've got your hand up as well on this.
I mean,
Yeah.
just Diane's given a link to that's in the report you've given a link to in the chat that will be obviously circulating in the report of the meeting.
That was related to the last question, but on this question, on this question about the difference between the uptake, that there is the UK dashboard where you can see the consistent data. I think Camille maybe wants to come in on this.
Yeah, just a quick one to say that it's not actually unusual for the devolved administrations to have higher uptake than England, unfortunately. I mean, it's a good thing because they've got higher uptake, but it's not unusual. Also, in terms of the rollouts, there were different timings for the rollouts. For example, Wales certainly rolled out to the 18 plus earlier than ourselves. So there are slight subtleties that will impact on the uptake overall as well.
This is Colin here. So I'd just point to differences in age structure and ethnic makeup in populations as well, which are going to be contributing to real differences in uptake, as opposed to sort of artifactual ones from use of various denominators.
Right. Now we've got the thing where the questions in the chat interleave with answers. Any insight on why uptake is lower in city centres? I think that's for Camille, isn't it?
Yeah, I put something in the chat as well here. Sorry, Camille.
I can't see the chat actually, so it's a bit annoying.
No. Yeah, okay. So this is a mixture of reasons. So you've got, again, age structure. So a city like London has a lower age on average than some other places. So the vaccine rollout would have been later in some of those groups. What you have is deprivation differs between city centres and, say, outer suburbs. And so that will be contributing to variations in uptake, as well as things like ethnic makeup. So, areas which have high proportions of people or of ethnicities which have a low vaccine uptake will tend to have lower uptake overall. And added to that is the comment that Camille made earlier. And so university towns also with large student populations, we're seeing sort of low apparent uptake in those as well. And, there's a lot of student accommodation in city centres. So that's a variety of reasons.
Right. I think that's also answered in the chat, so no need to repeat that. I think there's the general question about the different denominators and to which Diane commented about when you're doing UK comparisons, you use consistent denominators, because obviously you've got denominators from mid-year population estimates, denominators from the infection systems. Diane, do you want to say any more about that?
That's the one we've just been talking about, so I think we've covered that. Yeah,
I think you have. Yeah. So right, going through. Right. Right. Another.
I think, Alison, there was something people were talking about around those people who've been vaccinated and then getting the Delta variant. And obviously there's a sort of possible expectation that that's because they've got underlying conditions and frailties. But I'm not sure if anyone's actually done work specifically looking at trying to identify that population that's had both vaccinations and is getting the Delta variant. I know we sort of touched on that. I don't know if anyone wants to talk about whether there's anything that you can say about the type of people who've been vaccinated and are still getting the Delta variant. Anyone able to respond on that one? No? No one's...
If you don't want to comment...
It's quite difficult to do, isn't it?
So there is some work published in Scotland just looking at the numbers and kind of the age structure and the like, but there's more work ongoing at the moment looking at, in more detail at those individuals. So probably not got anything else to say at the moment. Chris, I don't know whether you want to say anything.
Because nobody wants to say anything. I mean, it's really quite complex at the minute because there's admission to hospital, and then there's also how long you're in hospital for. And as I said before, largely the biggest group of people who have had 2 doses of the vaccine are elderly, and elderly people tend to have comorbidities. And there's also some indications that the vaccine, even if you test positive, the vaccine helps to prevent hospitalization, which I showed in my slides. But also I've looked at how long are people in hospital, and there's some emerging evidence, but it's really very preliminary, that even if you're admitted to hospital and you've been vaccinated, you're less likely to stay in as long as you might have if you're unvaccinated. But that's conditional on the same age, the same comorbidities, and the likes of that. So it's quite complex analysis as well.
Yeah, it's quite difficult to unpick. Colin wanted to say something.
Yeah, I was just to add, I mean, it's not my particular area, but there is a technical briefing that's available publicly, which does look at sort of variants of concern and does address sort of hospitalizations and deaths. And I've just put a link to that in the chat for everyone.
Great, thanks. Well, we'll capture that and then it'll be in the notes for everyone, because just to remind everyone, not everyone can see the chat, so we'll be picking up the chat afterwards and making sure that's available. There was one question I know that maybe this is sort of, unless Alison Scotland is sort of starting to bring questions to it, is about long COVID. And I know that's almost like a trailer for our next, there's 2 more webinars. When we do the wrap up, there's 2 more webinars coming looking specifically at long COVID. But has any of the speakers actually got any information around vaccination and the long COVID? Does that actually reduce your chance of getting long COVID, or is it just too early to say? So if you're vaccinated and you get COVID, is it actually a milder case and therefore you don't get the long COVID? Is there any information on that so far?
I don't think there is. I don't think there's any, not to my knowledge.
I think we should leave that one to next time.
Yes,
yeah,
well, that's
definitely.
the trailer for the next webinar. Yes, yeah.
Right.
Sorry, Alison, I chipped in there. Have you got other questions to pick up on?
I've got questions for Simon and for Ted about linkage rates. I mean, for Ted, about linkage rates of the infection survey, and whether linkage rates vary by social class. Ted, you replied about the difference between linking to NIMS and linking to Census. Do you want to expand to the people who haven't got the chat?
Yeah, just to say quite briefly, the linkage rates and the way in which we receive the NIMS data, we can only calculate linkage rates using the NIMS data as the numerator, which essentially means that we can only calculate linkage rates from characteristics that are present in NIMS, which for our data set is currently only age and sex. So we can only look at the linkage rates by age and sex, which we have found to be roughly similar in the unlinked and linked populations, but we can't extend that to any of the other characteristics, unfortunately.
Thanks. And a question for Simon about well, I'm not quite sure whether this is for Simon or for Ted. That's saying difference for some variables we have individual data and some we have neighbourhood data, and suggesting if gender was defined by the proportion of females in your neighbourhood.
I put a comment in the chat. Thank you. It's an important point because for some level of analysis, we do base it on aggregated data. And to provide the really operationally useful feedback, we'll have to drill down to the next level to look at, even within, for example, the most deprived quintile of areas, what's the distribution by age and sex and ethnic group there. So it's a good point, and it's something that we are working on.
And Ted also responded to that, I think.
Yeah, just to add to the fact that the advantage of linking to the census data for us, although it comes with lots of caveats, and working with a subset, is that it allows us to link to individual level socioeconomic indicators such as the National Statistics Socioeconomic Classification, educational attainment and household tenure. So we're not just limited to the index multiple deprivation, area deprivation measure.
Thank you. I think that's everything that has come up.
Camille's just got her hand up there. I mean, she wants to chip in with a comment.
Sorry, it's just to clarify that the way that we allocate the data in the NIMS is based on postcode from the GP record. So a lot of the demographics is, for example, ethnicity does come from the GP record. The particular measure that we use is actually aggregated with data coming from hospital episode statistics, so HES data. The methods for that is on the NHS digital website that we can share as well, if people are interested in that.
Great, thanks. Yes, obviously anything that you want to post or send us in terms of links or anything else we can put into the report that will be posted on the website. So that's always helpful. So Alison, is there anything more in questions, or are we moving on?
Nothing more that I can see in the chat.
Right.
Colin has put a link on there, which is he's mentioned. I think it's all been covered. If anyone has put something in the chat and doesn't feel it's been covered, perhaps they might want to put their hands up.
Or email us. Obviously, there's an email address that you have that you can email us if you suddenly think, oh, I've got a thought afterwards. That webinar address, please feel free. You can use that after the webinar as well. And then we will be capturing all of this, and we will be giving the speakers an opportunity to add any further comments onto what they've actually put responding in the chat, so that we can actually put that together in a report that we will be posting. And then, so first of all, thank you very, very much to all the speakers. I mean, it's covered a lot of different areas, and that was really, really fascinating. And thank you to all the people who contributed in the chat and the comments, which I think raised some very, very important issues, several of which we kind of say, well, we can't do now. Maybe that's going to be a future webinar. We're still working on it. So, continue to involve yourself and keep an eye on what's being planned for these webinars or in the discussion on the website. I did mention, a sort of trailer for long COVID, that obviously long COVID is a really important issue of concern. And there are 2 webinars planned. There is something called the Stats User Network, which is linked to the Stats Usernet, who are now starting to hold a series of webinars on releases that are being published, ONS releases. And there is one coming up on the 21st of July, which is on long COVID, and will be presenting a couple of releases, recent releases, one that's I think just come out, and there's also a release that will be coming out on the 21st. So that webinar will be an opportunity for people to hear a bit more detail about the release and also do the sort of question and answer. So look out for that on Stats Usernet. There will be publicity coming up there for that 21st of July one. And then the next webinar in our series on statistical methods, looking at methods across the sort of 4 countries and in other areas, will actually also be on long COVID. So not just looking at the results, but actually the methods used. And that is going to be after the summer, so that is planned for September. We haven't got a date yet, but by then, hopefully, there'll be a bit more information and more work done on non-COVID and more to present. So keep watching this space, watching the website, and to look out for the details of that one. So that's the planned webinars. And if you think there's something else you think would be useful as a sort of webinar topic, please do feel free to, once again, email us on that webinar address and let us know. So I think that's probably as anything else that needs to be said, unless any of the speakers or organisers think I've forgotten something and want to chip in on a final point. So I think not, as we're sort of almost out of time. So once again, thank you very much for all your contributions, speakers, participants and organisers. So look forward to the presentations on the website, the recording, which will be coming up a few days afterwards, and then also the report, which obviously will take a week or two to put together to give us a chance to make sure people can comment. And then look out for future events. We welcome comments at any time. So thank you very much, and enjoy the rest of your day.